Okay, good afternoon and welcome everyone to this month's Employee Benefits Compliance webinar. As we get started, you will see two polling questions appear on your screen on the topic of 2026 medical renewals. As we know, many of you recently wrapped those up. So please do take a moment and provide your responses. We are very curious to hear your responses on this topic. And again, I'd like to welcome you to today's compliance webinar. I am Jenny Biddle with HIPAA Global, and today the Loomlight team will provide a year in review and look ahead into next year and beyond. And this is our final compliance webinar of 2025. Certainly, we thank you for joining us throughout the year. And we would like to extend a special thank you to your local benefits advisors and consultants who are partners of HIPAA Global for making today's webinar possible. We do welcome your questions today. So if you do have questions at any time throughout our presentation, please submit those over to us using that the Q&A function at the bottom of your screen. We will address as many of those questions as we can throughout our presentation here today. And if you have just joined us again, you'll see some polling questions up on your screen. Please do take a moment and respond to those if you are able to. And I will keep the poll open for a few more moments here as folks are still trickling in. And as I do that, I will remind you, we do record these webinars. A link to the recording will be available from the benefits advisor who invited you here today early next week. So you can reach out to them if you would like a link to the recording, if you'd like to revisit this content or maybe share it with a colleague. That benefits advisor will also be able to share the presentation slides with you, and I will also drop a link to those slides into the chat in just a moment. Okay. Looks like those poll responses have slowed down. I'm going to give it just another second and I'll share those out with everyone. We know that it was a tough renewal season for many employers, so if that was the case for you, we hope you were able to navigate that as best as you could. Okay, so we see kind of actually a range, but it looks like a fair number of our respondents were kind of in that 7% or above, and actually a fourth of you were 10% or greater. So certainly that was a little difficult to absorb, I have no doubt. And when we look at what changes were implemented, it looks like almost half of respondents understandably had to increase those employee contributions, changing plan designs, and some other impacts. So as always, we certainly appreciate you responding to these polls. And I do hope that you stick around until my final comments at the end. We do have a couple of related polling questions during my closing comments. But for now, I would like to welcome our presenters from the Loomlight team. Joining us today, we have Delaney George, and we also have Dan Brady, both senior consultants with Loomlight. So Dan and Delaney, thanks for being here today, and I will hand things over to you both.
Thanks, Jenny. All right. So as Jenny mentioned, today's topic is going to be kind of a review of major changes and big news that took place in the employee benefit space over the past year. And then at the end, we'll spend a little bit of time looking at 2026 and some of the noteworthy news and updates that we're aware of at this point. So as you can see, here's our agenda. I'm sure a lot of these things you are already familiar with, but we thought it would be helpful just to do a bit of a review. So starting off with the One Big Beautiful Bill Act, this was probably one of the more significant benefits related changes that we got in 2025. This was signed into law in July of this year. There were various employee benefit provisions included in the bill that I'll go over, and then also a few items that didn't quite make it into the final version that I wanted to touch on as well. So telehealth, many of you probably remember during COVID-19 pandemic to encourage individuals to avoid hospitals, Congress passed relief that permitted plans to cover telehealth and other remote care services before the participant satisfied their HDHP deductible, without impacting HSA eligibility. After COVID, that relief was extended on multiple occasions, but most recently it had expired at the end of the 2024 plan years. The act has now made that relief permanent, and this took effect back retroactively back to the start of 2025. So what that means is that employers can incorporate non-preventive telehealth and other remote care services for less than fair market value or at no cost at all prior to the individual satisfying that IRS minimum HDHP deductible without it impacting HSA eligibility. And that would include standalone telehealth benefits as well. If they haven't already, employers that sponsor HDHPs that provide telehealth would probably need to review and most likely amend their plans to include these changes. And again, the plans can be amended so that the changes would apply retroactively back to January 1st of 2025. The act also includes some changes to direct primary care arrangements. As a bit of a refresher, DPC arrangements typically involve a patient paying a fee, which is done monthly or sometimes annually, directly to the provider for services. The consensus was that because these arrangements provided first dollar coverage for non-preventive care, that the DPC arrangement was considered disqualifying coverage for HSA eligibility purposes. Now, under the Act, beginning in 2026, participation in these arrangements that meet certain criteria will not cause a loss of HSA eligibility. Those specific requirements are that the DPC arrangement must involve medical care provided by a primary care practitioner, and then they cannot be subject to a fixed monthly fee greater than $150 for an individual or $300 for a family. In addition, the Act clarified that any of those fees that are paid for these arrangements are treated as eligible medical expenses for purposes of HSA reimbursement. And then, just as a reminder, these changes are set to take effect January 1st, 2026. Lastly, the Act had some impact on marketplace and exchange coverage. So prior to the Act, certain bronze or catastrophic plans did not qualify as HDHPs. Now, starting 1/1, these plans are considered qualifying HDHPs, which means that individuals enrolled would also be HSA eligible, assuming they otherwise met the HSA eligibility requirements. Since this applies only to individual market plans, it really will have relatively little impact on employer-sponsored coverage. The one exception would be if the employer was offering an individual coverage HRA or a small employer HRA, because those are tied to individual coverage. And then I do want to mention quickly is that a week ago, actually, the IRS issued some additional guidance addressing common questions regarding the HSA changes in the One Big Beautiful Bill Act. The guidance clarified that otherwise eligible individuals enrolled in an HDHP before July 4th of 2025 that were provided telehealth services before the deductible are still HSA eligible for 25. The guidance also defined telehealth and remote care services as those payable by Medicare, and then they included some other language for services that meet certain criteria under applicable HHS guidance. And then also the guidance provided some clarification regarding direct primary care arrangement fees and provided that if the arrangement provides services other than permitted primary care services, the members in those arrangements cannot decline the additional services and treat the arrangement as a DPC to remain HSA eligible. Also, if enrolled in both a direct primary care arrangement and HDHP, you cannot count DPC fees towards your annual deductible and out-of-pocket maximums. There were some other non-HSA related changes in the Act. I'll talk a little bit about dependent care assistance programs in a minute. Student loan payments. So beginning in 2026, employer student loan payments or reimbursements of up to $5,250 indexed annually will continue to qualify for tax favored treatment as a type of educational assistance program. Some updates to transportation benefits. So beginning in 2026, the ability to reimburse employees for bicycle commuting expenses on a tax favored basis will no longer be available. However, other transportation and parking benefits were not impacted. So along with the telehealth relief, I think the DCAP changes were probably the most impactful change to come out of the One Big Beautiful Bill Act in terms of group health plan rules and regulations. Since 1986, with the exception of a short period for during COVID, the DCAP limit has always been $5,000 because for whatever reason, Congress decided they did not want to index that amount for inflation. But as many of you are aware now under the Act, that annual maximum reimbursement limit was increased from $5,000 to $7,500. And this new increased limit will apply on a calendar year basis beginning January 1st, 2026. I do want to mention that that amount was not indexed either, meaning we're going to have the $7,500 limit until Congress decides they want to change that again. There are a few important considerations that I want to mention. So the increased DCAP limit applies on a calendar year basis beginning in 26 and not on a plan year basis. So employers who want to adjust their plan limits have a few different options. For calendar year plans beginning 1/1 here, that's going to be pretty straightforward. The employer can increase that limit during open enrollment. I assume because most open enrollments are either already over or are going on right now, employers who do want to take advantage of that already have. For non-calendar year plans, the employer essentially has two options. They can either wait for the plan renewal date, so they keep their $5,000 limit through the 25 into 26 plan year, and then bump that limit up for the 26 to 27 plan year. Otherwise, they can adjust that limit effective 1/1. That would allow participants to make election changes mid-year to increase their annual elections as of January 1st. But the employer would need to limit the increase so that it won't result in over contributing moving on to the next year. Essentially, the goal is to allow the employee to increase their election for the remainder of the plan year in 26 while also allowing them to elect the full 7,500 in for the 26 to 27 plan year. If you allowed them the full 7,500 in the 25-26 year, you would have to limit the amount they can elect for 26 into 27. One other thing to keep in mind is that this increased limit is optional. Employers are not required to allow the entire contribution amount. On its face, the increase is certainly can be helpful for employees who want to take advantage of the ability to exclude that additional $2,500 from income. However, employers do need to consider that the increased limit may make it more difficult to pass applicable non-discrimination testing under the code. And just as a bit of a reminder, DCAPs are subject to Section 129 non-discrimination rules, as well as Section 125 non-discrimination rules if offered through the cafeteria plan. One of the discrimination tests under Section 129 is referred to as the 55% average benefits test, and that essentially looks at the average benefit received by your highly compensated employees as a ratio compared to the average benefit received by non-highly compensated employees. Um, Historically, your highly compensated employees tend to disproportionately elect more DCAP benefits, which already makes that 55% average benefits test one of the most commonly failed non-discrimination tests out of all of the code's non-discrimination tests. And so, assuming that trend continues and HCs will continue to disproportionately elect the maximum benefit, increasing that limit to $7,500 is going to make it even more difficult to pass those non-discrimination tests. So that's certainly something to keep in mind for employers who have had issues in the past. Finally, there were some changes to Medicaid, specifically coverage and eligibility changes, which are going to take effect over the next few years. This includes things like work requirements, more frequent eligibility redeterminations, eliminating eligibility for undocumented aliens. And these changes can result in current Medicaid recipients losing their eligibility for Medicaid. Um, as most of you know, the loss of Medicaid eligibility is a HIPAA special enrollment event. So that would require the plan to allow those individuals enroll in the employer-sponsored plan mid-year. So employers may want to anticipate a potential influx of these former Medicaid participants over the next few years. And then it could also lead to an increase in just group health plan enrollments as subsidized individual policies become presumably less attractive for individuals. And then I did mention there were a few things that didn't make it into that final version of the bill. Um, it included mostly design changes to individual coverage HRAs or ICHRAs. There were also a few proposed changes that would have had significant impact on HSA eligibility. Specifically, they were going to allow individuals enrolled in Medicare Part A or those who were covered under their spouse's health FSA to remain HSA eligible. Those would be some pretty significant changes in sort of the benefit regulatory space. Obviously, nothing to be concerned about yet because, like I said, these didn't make it into the final version. But it is good to kind of know that these things are at least being considered. And obviously, we'll all be watching out should any changes take place in the future.
Thanks, Dan. I'm going to be going over some updates related to the ACA from this year. One thing that we got from this past year is we got our final say from the U.S. Supreme Court on the Braidwood case, which actually began back in 2020 when Braidwood management challenged the constitutionality of the ACA's preventive care services mandate, which requires preventive services be provided without cost sharing. And what constitutes preventive services for that purpose is determined by advisory boards, including the United States Preventive Services Task Force. And that is what Braidwood had a problem with. They claimed that because task force members were and are appointed by the Secretary of Health and Human Services versus being appointed by the president with Senate confirmation, that it was unconstitutional for them to be making these kinds of decisions. And the lower courts actually agreed with Braidwood. Back in 2023, you may recall there was a national injunction issued, and it caused all sorts of questions about what does this mean for our coverage and our plan. And luckily, we don't have to go through the answers right now because it all ends up here after the government petitioned the Supreme Court to review the case. And the Supreme Court reached the opposite conclusion than the lower courts, that the ACA's preventive services mandate and how those preventive services are determined is constitutional. So ultimately, nothing has changed. Non-grandfathered group health plans continue to be required to provide preventive care without cost sharing. And those preventive care services are determined based on the designated advisory boards and their recommendations. Speaking of those advisory boards, one, the Health Resources Services Administration did make some changes to preventive services, specifically for women. And these were actually published a year ago in 2024, but these changes are becoming effective for plan years beginning in 2026. And that includes additional screenings and follow-up exams for breast cancer following an initial screening that indicates a potential issue, as well as ongoing coverage for intervention services for victims of domestic violence. Previously, it was just the initial coverage, initial screenings that were considered preventive, and now that is kind of expanded to ongoing or follow-up screenings. So, and then also under the umbrella of preventive care is included contraception and contraceptive coverage. So contraceptive coverage does need to be covered without cost sharing. However, the ACA final rules were written with an exemption for religious employers. Then through a series of regulations and a Supreme Court ruling in 2020, that was expanded to allow any employer to claim a religious or moral exemption to contraceptive coverage and allow those employers to exclude that coverage from their health plans. However, this past August, a court ruling out of Pennsylvania vacated those rules, providing that expanded exemption. So that is no more. And now the only exemptions to the requirement of providing contraceptive coverage without cost sharing as a preventive service are that original exemption under the ACA final rules for religious employers. And then certain entities, nonprofit and closely held for-profit entities, do have the option of an accommodation process where if they do have religious objections to providing contraceptive coverage, they can go through this process and the coverage actually still ends up being provided, but not directly from that employer. It ends up being provided by the carrier or the TPA, depending on if the plan is fully insured or self-funded, but the employer doesn't have to provide that coverage. Other ACA updates, employer mandate enforcement efforts. Right now, we know that the IRS is currently working on enforcement for the 2023 calendar year. And just as a reminder of what those enforcement efforts look like, the IRS may send a letter 5699. That letter will go out to employers who have submitted enough Form W-2s that it would appear that that employer could be an applicable large employer, ALE, subject to the employer mandate, but that employer has not actually submitted that required reporting, the Form 1094, 1095Cs. So that letter gets sent to get that reporting in. And then there is the letter 226J, where employers who did submit their reporting will receive a proposed employer shared responsibility payment, ESRP, or we call it a penalty too, penalty amount under 4980H from the IRS based on the reporting that the employer did submit and any subsidized marketplace enrollment from their employees. Importantly, just when anybody receives one of these letters, the worst thing that an employer could do is ignore it. It needs to be responded to. That said, one ALE that did receive a 226J did respond and then some. So as you may know, a 4980HB penalty will apply if an employee is offered unaffordable coverage and that employee enrolls in subsidized marketplace coverage. And the ACA actually states that before an employer can be subject to that B penalty, they should receive certification from HHS when an employee does enroll in subsidized marketplace coverage, so that the employer actually has the opportunity to appeal that enrollment or that subsidy. And the plaintiffs in this case, Folk, firstly, they received the 226J and they did pay the penalty under protest, and then filed a complaint claiming that they should get a refund because they never received that certification from HHS. HHS's counter argument to that was that the letter 226J from the IRS was that certification itself, and that HHS had delegated that certification duty to the IRS. But in April of this year, the court issued its opinion disagreeing with that argument, saying that the ACA authorizes HHS, not the IRS, to make that certification. And so this employer was refunded that penalty amount. And now an appeal has been filed to that decision. So I'm sure we haven't heard the final say here, but in the meantime, that's the lay of the land. And so what does this mean right now for employers? And firstly, offer of coverage and reporting requirements for ALEs are not affected. They should continue to offer coverage, continue to fulfill their reporting. For employers that do receive a 226J that says that they owe a B penalty amount, this could potentially be raised as a defense to that penalty if in fact that employer did not receive that certification. Just because Folk didn't receive that certification doesn't mean that all employers don't get that certification. Because it can come not only from HHS, but state marketplaces are also authorized under the ACA to send those certifications. So if an employer did get one of those, then that requirement has been met and the penalty can be applied. Staying on the employer reporting theme, we had some welcome updates on Form 1095 distribution requirements this last year. Employers can still deliver by hand, mail, electronically with consent, or the new option starting last year is posting a notice of availability. And to fulfill that distribution method, employers post a notice of availability of the Form 1095 on a public website, something that is accessible to all potential Form 1095 recipients. So something like a benefits portal, only accessible to employees, likely won't work. But get that posted on a public website by March 2nd, leaving that post up until October 15th. And in that notice, have to have contact information for folks to request that Form 1095. And that contact information does have to be an email, mailing address, and phone number. They need to have all three, not just one of those. And then when if an employer does get a request for a Form 1095, then that form must be provided within 30 days of the request. And then the employer has met their distribution obligation that way. Finally, wrapping up ACA updates with some marketplace changes this year. In June, CMS issued the 2025 Marketplace Integrity and Affordability Final Rule that they made some changes with the overall goal being to reduce waste and fraud in the marketplace. These changes included shortening the open enrollment window, increased eligibility verification and reconciliation for premium tax credits that will involve income verification of participants, adjustments to how premiums are set. And these adjustments mean that they'll now consider premium changes to both the individual and employer-sponsored insurance markets when setting premiums on the marketplace. That said, in August, a Maryland court did issue a nationwide stay on parts of this final rule. So the court temporarily blocked several of these provisions. So enforcement is on hold for some. Importantly, the new methodology for premium determination was not one of those provisions. So that new methodology will affect plans in 2026. Then finally, there have been the COVID era premium tax credits still in place. Originally established under the American Rescue Plan Act in 2021. Those are expiring as of December 31st, just a couple weeks away. And while there's certainly been efforts to extend these, that just hasn't happened. So a lot of people will either no longer qualify for their premium tax credit or it'll be lowered. And one thing that I want to note here, because we've gotten a few questions along these lines already, is that the loss or lowering of a premium tax credit will not trigger a HIPAA special enrollment period for employees to be able to jump onto their employer plan mid-year. And I'm sure that'll come up for folks as we head into the new year. All right, Dan?
Yeah, thanks. All right, so wellness program litigation. I'm sure most of you at least came across a headline regarding some wellness program litigation, so it would seem to certainly be a popular topic this year that we wanted to touch on. Just to give a little bit of background to provide some sort of context for that recent litigation. So wellness programs that are subject to HIPAA, including those that themselves are considered group health plans or that affect the employer's group health plans, for example, it could provide a reduction or increase surcharge in contributions towards premiums or cost sharing. Those programs are subject to certain rules. These specific requirements depend on whether the program is considered a participatory program or a health contingent program. Just a reminder, participatory means there either is no reward or the reward is not conditioned on achieving any sort of health-related outcome or result. Health contingent programs are further broken down into two separate categories. You have activity only, which are programs that require the individual to perform or complete a health-related activity, for example, a walking step challenge. And then you have outcomes-based programs, which require a specific health outcome, for example, hitting a BMI or cholesterol target. So focusing specifically on health contingent programs, there are several specific requirements that apply, including uniform availability, frequency of reward, the size of the reward or surcharge, reasonable design requirements, and also the health contingent programs must include what is referred to as a reasonable alternative standard. You all are probably familiar with this. But essentially, it's an alternative way for a participant to achieve the reward who does not meet the initial standard. Not only does the RAS have to be available, but the employer must disclose in all materials describing the program the availability of the RAS to qualify for the reward, and then who to contact for more information. So the recent litigation focuses exclusively on health contingent programs. One of the most common examples of a health contingent program we see is a tobacco surcharge, where employees are penalized if they use tobacco. The most common RAS associated with these programs is a smoking cessation program, where individuals can earn the reward or avoid the surcharge if they attend a smoking cessation program, regardless of whether they actually quit smoking or not. In the last year or two, we have seen several, or really a significant uptick in litigation regarding tobacco surcharge programs, including several class action lawsuits that are targeting, large corporations and also lawsuits that involved much smaller employers. Many of these lawsuits allege HIPAA violations centered around failures to provide, notify, or correctly administer the tobacco surcharges RAS. Couple examples: Whole Foods, back in January, several current and former employees filed a class action against Whole Foods alleging that the surcharge program failed to offer a RAS because it did not offer the full reward to participants who completed the RAS. It alleged the program provided only a prospective refund after completing the RAS. Also, that proper disclosure of that RAS program and its details were not provided. The travelers companies in July of this year, employees alleged that travelers failed to disclose the availability of that RAS and other communication failures. They also alleged that the employer breached their fiduciary duty under ERISA. That it does seem to be kind of a catch-all that's included with a lot of these HIPAA wellness program lawsuits. I do want to mention that not all of the lawsuits end in favor of participants. In many cases, the courts are siding with the employer. Regardless, the takeaway is that employers should be making sure that their wellness programs, specifically those health contingent programs, are including an RAS, that the required notice is provided. If people are satisfying that RAS, they need to make sure they are getting the full reward or avoiding the full surcharge. So certainly something to keep in mind moving forward. We expect that litigation to sort of continue.
Right. Creditable coverage status, perhaps familiar requirement where, as you may know, individuals who are eligible for Medicare Part D can delay their enrollment, but will incur late penalties if they go 63 days or more without other creditable prescription drug coverage. And to help folks know or be aware of whether their prescription drug coverage is creditable, any plan that does offer prescription drug coverage is required to notify employees and CMS of the plan's creditable status. Importantly, plans are absolutely not required to offer creditable coverage. There's no penalty or anything whatsoever if a plan is not creditable, but they're just required to notify individuals and CMS of that. And the reason that this familiar requirement is included in this presentation is because there are some updates this next year in how a plan can determine their credibility status. For 2025 and previous years, plans could either use one of two methods: the actuarial method, where they have an actuary compare their drug coverage with Medicare Part D, or they could use the simplified method, under which a plan is deemed creditable if it ticks off 3 check boxes. And CMS revised that simplified method. And so for 2026, the revised simplified method is now available also. It is a slightly higher bar, this revised simplified method, so fewer plans would be found creditable under that, but and again, no penalty associated with that. But for 2026, plans can choose from any 3 of those methods: actuarial, simplified, or revised simplified. The idea being that eventually the revised simplified method would replace that simplified method, but just as a matter of transition, both methods remain available for 2026, though it's not clear how long that original simplified method would still be available beyond 2026. So good thing to keep in mind.
Okay, so we also had some mental health parity changes earlier this year. Just some very quick background. The Mental Health Parity and Addiction Equity Act is a federal law that requires certain group health plans to treat mental health and substance abuse disorder benefits no more restrictively than they treat medical surgical benefits. The act requires parity, as the name suggests, in financial, quantitative, and non-quantitative treatment limits. This year we had some period of, or are in a period of temporary non-enforcement. So in May, a federal court granted a request from the DOL and HHS to pause litigation regarding the 2024 mental health parity final rule, while the departments kind of reconsider and modify or rescind the rule through new proposed rulemaking. Um, the departments announced that that non-enforcement period is going to last until the court decision in an ERISA industry committee lawsuit plus an additional 18 months is over. So what does all of this mean? Well, there are several requirements that are not currently being enforced, and that includes some benefit requirements, data collection requirements, and then also that requirement that ERISA plan fiduciaries sign off on compliance with the act. That was kind of a major pain point. I know when it came out, we got a lot of questions about that. So right now, those requirements, there is a current temporary non-enforcement period going on. That being said, the department's made it very clear that the framework for the act that existed prior to that 2024 final rule is unaffected. That includes the general parity requirements that I mentioned, and then also that written comparative analysis requirement for NQTL. So employers are still very much required to adhere to the parity rules and complete that comparative analysis. Again, just a reminder that a comparative analysis does need to be provided if requested by the agencies or an ERISA plan participant. So a good reminder.
Right. Everybody's favorite. You may recall in April 2024, HHS issued the 2024 privacy rule, which introduced this whole new category of a prohibited use or disclosure of protected health information, or PHI, potentially related to reproductive health care. The catalyst for that rule was really due to the Dobbs decision overturning Roe v. Wade, and you had a lot of states introducing abortion restrictions or bans, and HHS passed this 2024 privacy rule in an effort to provide additional protection for reproductive health care, PHI. There was a compliance date back about a year ago, December 2024, and we all got our HIPAA policies updated and ready to go. And then this past June, a Texas court vacated almost the entire 2024 privacy rule, specifically that new category of prohibited use or disclosure of PHI related to reproductive health care. So really we could all just revert back to the HIPAA policies we had in place before the 2024 privacy rule happened. However, one piece that was not vacated by the court were some updates to the notice of privacy practices that covered entities, including group health plans, need to distribute. These updates are related to use of PHI related to substance use disorder, so not related to reproductive health care. And covered entities, including group health plans, are expected to comply with these updates by February 16th, 2026. We do still hope that HHS will release an updated model of the Notice of Privacy Practices that complies with these updates that folks can use for that update. And then once your Notice of Privacy Practices is updated, it does need to be distributed within 60 days of any material changes, and that's just a distribution requirement. So that is something to keep an eye out for. As a reminder, too, also this year, almost an entire year ago, at this point, HHS did release some proposed changes to the security rule under HIPAA. I want to emphasize the word proposed because these are not final or effective in any way. We really just wanted to include these as something to continue to keep your eye out for, because when any finalized rules may be released, it's hard to tell how these would be prioritized for publication. For now, in the meantime, it's always prudent to review security protocols on a periodic basis anyways. And while these are proposed rules and the finalized rules may even look a bit different, the proposed rules do kind of inform us a bit on how the agency is looking at these requirements right now. For example, part of the reason they're looking at eliminating the distinction between a required and addressable security items, for example, like data encryption. They're eliminating that distinction because they have found that a lot of covered entities mistakenly understand addressable to mean optional, which that is not the case. It just means that an alternative needs to be used. So just one potentially helpful thing to keep in mind when reviewing security protocols next time around.
All right. ERISA fiduciary litigation. So for whatever reason, 2025 seems to be kind of the year of major litigation. Just as a bit of a reminder, under ERISA, plan sponsors are considered fiduciaries of the health and welfare plan and must perform their duties solely in the interest of participants and beneficiaries for the exclusive purpose of providing plan benefits or defraying reasonable administrative expenses with the care, skill, prudence, and diligence of a prudent person. And then finally, in accordance with those written governing plan documents. So this year we had some recent litigation regarding ERISA fiduciary duties. Johnson & Johnson and Wells Fargo cases both included claims that the fiduciary mishandled prescription drug coverage, resulting in plan participants paying higher premiums and higher cost sharing. Both of these were dismissed due to lack of standing. The J&J claim was actually refiled and actually just dismissed again, I believe, the last week of November, so pretty recently. The JP Morgan Chase similarly claims of mishandling prescription drug coverage and mismanaged PBM relationships. Although it's not uncommon for these to be dismissed in favor of the employer, there continues to sort of be a lot of focus around ERISA fiduciary issues, and it's really important that employers maintain compliance with their fiduciary obligations. We've included a few possible actions to kind of help manage that. So, creating benefits committees, performing regular compliance assessments to identify and address any issues, making sure your participant contributions and plan assets are appropriately collected and handled, performing claims and dependent audits, fiduciary liability insurance. And then one area that is especially true is with respect to doing due diligence when selecting plan vendors, and then also monitoring the vendor's actions throughout the relationship. So employers should consider and compare multiple vendors when they're trying to select a vendor, document that selection process. If there's a benefits committee that, that's the group that would handle this. Ensure only, reasonable and necessary fees are being paid, and just, make sure you're monitoring and continuing to do compliance assessments just to identify any potential issues.
Okay, so yeah, in this section, we're just gonna look at some items that, based on questions, seem to be hot topics. So, and then we'll get into some deadlines and limits for the 2026 year. First up, Trump RX and most favored nation prices. This was back in September. The Trump administration announced a deal with Pfizer that Pfizer would offer its drugs to Medicaid at the most favored nation price, which just this term refers to the lowest prices paid for prescription in other developed countries. And then alongside that announcement were plans for Trump RX, which Pfizer has said it would participate in, which is described as a website that will connect Americans directly with drug manufacturers to buy prescriptions at discounted prices. And my understanding that is going to be possibly up and running in January. However, for our purposes, the reality is that for insured individuals, even these direct-to-consumer prices would likely still be more expensive than what their prescription drug coverage would provide. And then any drugs that are purchased through Trump RX would then not count toward plan accumulators, like deductibles or out-of-pocket maximums. So for plan participants, Trump RX is not likely to be a good option. They'll still just want to utilize their coverage. Next, ICHRA trends. For those that are unfamiliar, ICHRAs, individual coverage HRAs, are HRAs that can reimburse an employee's premiums for individual coverage or Medicare, as well as qualifying medical expenses, just like a regular HRA. And ICHRAs are themselves considered self-funded group health plans, and thus have all of the compliance considerations that come along with a group health plan, but also have their own set of rules, including any individual that an employer offers an ICHRA to cannot also be offered a traditional medical plan. It has to be one or the other. Further, if an employer chooses to offer an ICHRA, it must be on a uniform basis within a specified class, and that class may need to meet certain class size rules, which can fluctuate with the size of the employer. But I want to note that there does exist an exhaustive list of acceptable employee classes for this purpose, like full-time, part-time, salaried, not salaried, and there's more, but usually with benefits differentiation, an employer has a lot more flexibility with designating a class, like by job title or department, but that is not the case with ICHRAs. There is a finite list of permissible classes. That said, ICHRAs continue to become more and more popular based on the stats that we've found, and just from our own experience, it seems like they've gotten more popular, and for good reason. They really are a good option for many employers who may have trouble meeting participation requirements, or may want to offer something to part-time employees. Can help alleviate some of the administrative burden. Ultimately, ICHRAs allow employers to meet their own coverage offer obligations while also giving employees quite a bit of freedom in terms of finding coverage that works for them. Next, this year, as in previous years, we have seen some more state-paid family leave mandates coming to fruition. These continue to be popular with the states. We already have 10 states with mandates in place, and a handful becoming effective this coming year in 2026. And then we do have Maryland becoming effective in 2028. Note that I believe for at least one of these upcoming states, maybe more, they may have started the payroll tax collection that funds the program a year ahead of when the leave benefits actually become available for folks. But what we have up here is the year that folks can actually start getting those leave benefits. There were also 16 other states that at least introduced their own paid family leave bills that ultimately did not pass, but that doesn't mean that they can't try again. They may come back around, and we don't see this trend going away. Finally, just some last minute reminders for the relevant limits for 2026. Major highlight here being the increased DCAP contribution. Like Dan said, unlike the rest, is not indexed annually, so a change here can be unusual, but otherwise pretty as expected numbers. A few more numbers that we have. Again, no major surprises here, just the typical incremental increases, though the affordability percentage is one of the biggest annual jumps since the inception of the ACA, so that is at least noteworthy. And then finally, last but not least, we have some compliance dates for you. These are specifically applicable to a calendar year plan, so they may change if you have a non-calendar year plan, but again, shouldn't be any surprises here. Though I will also take this opportunity to remind everyone of the upcoming gag clause attestation due date for this year on December 31st, just in a couple of weeks. So ensure that that is completed by then. Right.
So it looks like we had I got a couple of minutes. It looks like we did have a quick question about are you able to exclude highly compensated employees from participating in a DCAP to ensure passing non-discrimination testing? And yes, you are. I mean, that's probably one of the more, I guess, aggressive approaches, but particularly for like a small employer, that might be necessary. I mean, we've seen small employers where only highly comped employees are participating, so it's basically an automatic fail if you're going to offer a DCAP. Otherwise, you could reduce their contribution limits, or in some cases, an employer could provide like a contribution incentive for maybe non-HCs to participate by doing an employer contribution. Let's see.
There
It's like
is also,
yeah.
there's also a question on Medicare credibility and how that late penalty may work if an employee, Medicare Part D eligible employee, has non-creditable coverage for a couple of months and then enrolls in creditable coverage. Sounds like the question is, does that late penalty still apply? My understanding is that if you have 63 days or more with non-creditable coverage then you will at least start incurring late penalties. Whether that is told if an individual re-enrolls in creditable coverage, I'm not sure. Are you aware, Dan, or we can?
I think you're right. I think that even
Yeah.
if you have a big enough gap in non-creditable coverage that you can get hit with the penalties.
Yep, exactly. And then I think Jenny had some additional polls to wrap us up.
I do. Thank you both. I will get those polls launched. So our audience, you should see those up on your screen. They are on the same topic that we kicked off with, your 2026 medical plan renewals. So please take a moment and answer those questions as I go over a couple final things here. So again, thank you, Dan and Delaney, for your time today. Certainly we covered a lot of ground today. For our audience, if you do have follow-up questions or if you'd like to discuss how today's information applies to your organization, we encourage you to reach out to that benefits advisor who invited you here today. They can help you get any remaining questions answered. And as a reminder, we did record today's presentation, and a link to the recording is available from that benefits advisor who invited you here today. That should be available early next week, if not sooner. So please check with them if you'd like to revisit the contents. And certainly we want to thank those benefits advisors and consultants again. Those folks are partners of HIPAA Global, and they make this webinar series possible. We are going to leave this poll open for just a few more moments because we want to make sure we can collect as many of your responses as we can. If you join a lot of our webinars, you know we conduct polls every single month. We think it's really important to just get this timely information from all of you folks who are out here on the front lines every day. So we certainly appreciate you taking a moment to respond to these. We publish these every single month, the results from these polls, in what we call a market check survey. So I always will share the results with you here live during the event, but if you'd like to kind of do a deeper dive, keep an eye out for that market check survey, which is available from your benefits advisor or consultant. And I'll also give you a heads up, we are actually publishing HIPAA Global's annual year in review and market outlook. So that's a bigger document that's really diving into everything that happened in 2025 and how employers like you responded to that. And then again, looking ahead into 2026, that will be available here in the coming weeks. So I will close out this poll and show the results out to everyone. Primary driver of the medical plan, we saw catastrophic claims from about a fourth of you. Pharmacy and higher utilization kind of trailing behind there. So probably not a lot of surprises there. And when we're looking at what barriers are preventing many of you from making bigger changes, employee affordability and employee disruption, always looking at that employee impact. So certainly appreciate your responses there. With that, that does conclude our time together. Certainly appreciate your time with us here this afternoon. Thank you again for joining us. Have a happy holiday season, and we will see you in the new year. Have a great afternoon.